Hey Medicos, welcome back. In today's lecture, we are going to learn about very interesting topic, and yes, it is close to my heart because I am JR in the Department of Radiodiagnosis. I will make sure that after watching this video, you won't need to search for any other video to master ChestXRay interpretation. The next thing is, this lecture is very important for those who are preparing for NEET PG. Yes, obviously because they will go in first year and then interns and final year student, because in medicine viva they will definitely going to ask one chest x-ray. So this is very important topic and I will going to cover most of the important things. Don't worry about it. So let's talk about the reporting of chest x-ray. So first of all, we will talk about the indications in short, then we will talk about the introduction part, technical factors like rotation, inspiration, penetration. We'll talk about how to describe the lesion and what are the things we should mention while describing. Then we will do the systemic review. What are the normal parts we will discuss. At the end, we will summarize ki yes, these are my differentials. Why? Because these are the things. And at the end, we will give the further management part. Okay. So let's start about the indication part. So indications can be divided into three parts. It can be respiratory, it can be cardiac, or it can be surgical. So first of all, in respiratory malignancy, primary or secondaries, okay. Then infections like pneumonia, TB, and lot of infections are there. For that, we can recommend the chest X-ray. Then next is pulmonary embolism, pleural effusion. Then yes, inhaled foreign body, chest trauma, pneumothorax, and acute exacerbation of the asthma, again for the COPD. So for these patients, we will advise the chest X-ray. Then in cardiac, heart failure, then heart murmurs, we will. So for these patients also we can do the chest x-ray. Then for the surgical, like NG insertion that we have already done in our internship, if you are an intern, so we'll have to do the chest x-ray after the procedure, okay. Then central venous catheter position, again we'll have to do the chest x-ray because to look the position of the central venous catheter, okay. So these are the indications for the chest x-ray. Now let's move towards the reporting part, okay. So I gave you an x-ray and now I will ask, chalo karo ise describe. So first of all, what came into your mind? Yes. So the first thing you will have to do is you need to introduce the chest x-ray by checking the projection. So you'll have to check the projection and you will have to mention any available personal demographic information. Example deta hu. This is a PA x-ray of an adult female, or you can also add the age. So this is the PA x-ray of an 59-year-old female, like that. So it is really important to check you are reviewing the correct x-ray of a correct patient and from the correct date and time. In the exam, you will not be able to do this as an x-ray should be anonymized, but mention to remember examiner that you would wish to do this as a part of our usual practice. We can start like, this is the PA chest x-ray of a 59-old-year female done on dated 10 August at 4 o'clock, like that, okay. Now consider the technical quality. So we'll have to talk about the rotation, we'll have to talk about the inspiration and penetration. So we will talk these topics in detail because you will have to learn, then only you can speak. So first we will learn and then I will tell how to speak. Now first let's talk about the projection. So pay attention to letters PA. What is PA? Posterior anterior, or AP, anterior posterior, on chest x-ray, and also the word erect or supine, okay. The next thing is a standard chest x-ray is taken in PA in a erect position, that is patient is in a standing up with shoulders internally rotated, hands on hip, which moves scapula laterally, so they are less visible on the film. If any film is not labeled, this is default position. So you will have to speak like, this is the PA view if it is not labeled, okay. So we are getting the maximum information from the PA view. Then why we are taking the AP view? Yes, this might be the question from your examiner. So yes, we are taking AP view because it's very difficult to mobilize the patient, and next thing is patient is very unwell. So in such a conditions, we are taking the AP views. If suppose we took the AP view and we have the AP view, such a condition we will not going to comment on the cardiac part because the cardiac borders will be more prominent. We can misinterpret as a cardiomegaly. So we'll not going to comment on the cardiac part in AP view. Remember that. Your examiner might ask you a question, what are the differences between the X-ray, PA and the AP view? Okay, obviously you can ask. So the first one is, the clavicle is seen above the apex and this is seen in the AP view. We can see here, right? And in PA view, the clavicle seen over the lung fields. The next point is about the scapula. So we know that in PA view, inner border of the scapula seen away from the lung fields. However, in AP view, the inner border seen more over the lung fields. Okay. Then about the ribs. So in PA view, obviously posterior ribs visual better, and in AP view, anterior ribs better visible. And we already talked about that is apparent cardiomegaly. So we will not going to comment on the AP view about the cardiac size and cardiac shape. Now we will talk about the technical factors like rotation, inspiration and penetration. So first, rotation. To assess rotation, find the medial head of the clavicles and compare their distances away from the spinous processes of the adjacent vertebral bodies. Like this, from here you will have to see the distances. Okay, if the spinous process of the vertebral body is equidistant between the both clavicle head, then there is a no rotation. And suppose there is a less gap on the right and there is a more gap on the left, then patient is rotated toward the left side. Means if gap is more on the right, then the patient is rotated to the right and vice versa. So this is the rotation. Don't worry, I will give you an example how to speak. Okay. Then inspiration. Patient are asked to breathe in and hold their breath when chest X-ray is taken, so that the lungs are optimally visualized. Inspiratory effort is described as adequate when 9 to 11 posterior or 5 to 7 anterior ribs are seen. So we can say that the inspiratory effort is adequate. So in this patient we can say that there is a no rotation and inspiration is adequate. Then penetration. The vertebral bodies should just be visible behind the heart for adequate penetration. If chest X-ray is either over or under penetrated, then you will be not able to fully access all the structures and compare their densities accurately. An underpenetrated X-ray appears overly opaque, dense, or we can say both white hai, and an overpenetrated X-ray will appear too lucent, dark or black. So penetration should be adequate. So in our patient, yes, penetration is adequate. Okay. So till now our sequence is, this is the chest X-ray PA view of 59-year-old female done on dated 10 August at 4 o'clock. In this radiograph, there is no evidence of rotation. Inspiration and penetration are adequate. Now, after this part, we will have to describe about the obvious abnormality, like what is the abnormality, where it is, shape, size, density, associated factors. We will describe this part. But I wanted to explain first the normal anatomy and then we will go on the pathology. And at the end, we will arrange our sequence. Okay. So in systemic review, there are two approaches. The first one is ABCDE approach and another one is primarily used by radiologists, and this approach is like you can start from center to periphery and you can go from periphery to center, and this is the best approach I am thinking. But yes, for the memory and the starting point you can remember ABCDE approach and I will tell that. Okay, so in ABCDE, first one is airway, and in airway the first thing we will have to look for trachea. Okay, so trachea should be central. Deviation to the right may be related to the ipsilateral lung volume loss like collapse, fibrosis, or if it is a contralateral, then maybe because of the pneumothorax, hemothorax, pleural effusion, or large lung masses. So it should be in the center. Next one is breathing. So first of all, we will have to look for the lung apices. This should be compared. So they should be symmetrical and have similar density. Take care in this part because pathology here can easily be missed. Then upper, middle and lower zones. So follow the lateral borders down to the base and then up towards the hila. So compare both the sides. So in these areas, pneumothorax is most common. If you are shown a pneumothorax in exam, it will be usually a large and clearly demonstrated. Small subtle lesions will not be used. Okay, so don't worry. Next one is pleural angles. So we'll have to look for the costophrenic angle and cardiophrenic angle. We'll look for the blunting and increase in the density, as it can be seen with consolidation like in pneumonias, and pleural effusions or chronic pleural thickening can cause the costophrenic or cardiophrenic blunting. Next one is hila positions. So these are the hilas. Okay, so we'll have to look for the position, shape and density. the left should sit at the same level or slightly higher than the right one. So this is the normal position. The hilas are made up of pulmonary arteries, vein, bronchi, lymph nodes. So they should be equal in size, shape and density. Displaced hilum may suggest lung volume loss. A dense or enlarged hilum may be caused by lymphadenopathy due to maybe an infection, malignancy, sarcoidosis, or pulmonary hypertension due to COPD or heart diseases. Okay, so these are some pathologies here. आई थिंक ये लेक्चर बहुत मोनोटोनस जा रहा है, ऑलरेडी 10 मिनट हो चुके हैं. सो आई विल गिव यू एन एक्सरे. सो दिस इज़ द एक्सरे एंड आप मुझे इसकी फाइंडिंग बताओगे. सो यू कैन पॉज द एक्सरे इफ़ यू वांट और जस्ट राइट इन द कमेंट सेक्शन. सो येस, always remember to check behind the heart for a subtle mass in left lower lobe and also to assess the basal segments of the lobes through the upper abdominal diaphragm. Can you see the mass lesion here? Yes, it is behind the heart. Okay, so don't miss this finding. So it is not easy, huh? X-ray are not easy. Then fissures, look for the fissures. Check the normal appearance and position of fissures, as this will be distorted in the lobar collapse. Okay, so look for fissures also. So we are done with airway and breathing. So in circulation, we will have to look for heart size, mediastinal shift, aortic arch. Then we'll have to look for the left heart border and the right heart border. And at the end, we will look for the pericardium. So in heart size, when we will comment? Yes, if the film is PA. Suppose if you compare the width of the heart with that of the thorax, the cardiothoracic ratio should be less than 50% in adults. Okay. Cardiomegaly may be caused by heart failure. Then mediastinal shift. So if the heart no longer appears in the center of the thorax, then the film might be rotated. There may be volume loss or pulling structures toward the pathology like lung collapse or fibrosis, or suppose there is a volume increases, then it will pushing the structures away from the pathology, tension pneumothorax like hemothorax, okay, or large masses. So in such a condition, there might be mediastinal shift. Next one is aortic arch. So the aortic arch, look over here, this should be on the left side. If it is too small, then there could be an atrial septal defect. If enlarged, there may be hypertension, aortic stenosis, or aortic dissection. Next one is left heart border. So look over here, this is the left heart border, mainly from the left atrium or left atrial appendages. So suppose the left atrium or left atrial appendages may enlarge, so we can suspect the mitral valve disease. The left ventricle, here we have the left ventricular border. Okay, so maybe enlarged in volume overload conditions due to the aortic or mitral regurgitation, ischemia, or cardiomyopathy causing primary left ventricular disease, or maybe because of the pericardial effusion. Okay, if the left atrium enlarges, example in the mitral stenosis, this may be widen the carina. So this is the carina. Okay, so it can widen it because of the increase in the left atrial size, and this left atrium sits in the subcarinal region, so it may cause the double heart border sign. Okay, then right heart border. So it is mainly made up of the right atrium, so it can be enlarged in the conditions like tricuspid regurgitation. Pericardium, gas shadow around the cardiac slot, look over here like this if we can see, so can be seen maybe in the pneumomediastinum. Okay, so these are the conditions we will have to look for, and this is all about the circulation: heart size, mediastinal shift, aortic arch, left heart border, right heart border, and pericardium. Next one is diaphragm. So we'll have to look for the position and pneumoperitoneum. So position, the right hemidiaphragm should be slightly higher than the left due to the mass effect of the lever. There should be curvature in both. Your examiner might ask you why it is more down towards the left side. So don't confuse or don't tell the answer like there is a heart, that's why it is on the lower side. No, we'll have to speak like due to the mass effect of the lever, so that's why the right hemidiaphragm is above, okay, slightly higher. There should be curvature in both. If it is not, there can be significant pathology. Then pneumoperitoneum. So pneumoperitoneum is characterized by the free subdiaphragmatic gas on the erect chest radiograph. This is usually caused by bowel perforation and would warrant urgent surgical review. Okay, so this is about the diaphragm. Now we'll have to look for the everything else part, like lines and tubes must be commented upon, state whether they are adequately positioned or need replacing. That is, I'm talking about the nasogastric tube, endotracheal tube with central venous line and pleural drainage. We'll have to look for the cardiac device if it is there. We'll have to write the position, how many leads have the device and where they are terminated. We'll have to write this part. We'll have to comment on the if there is any lead fracture is there or not. Bone fractures, we'll have to comment for the clavicle, ribs. Make sure the acromioclavicular and glenohumeral joints of the shoulders are intact. Look for the rib metastasis. Breast contour in female, okay, in female you'll have to look for that. Note any asymmetry or evidence of previous mastectomy. There may be surgical clips. You will have to look all the parts. So what we have seen the airway, then we have looked for the circulation, then we saw the diaphragm, then we have seen the everything else part like lines, tube, cardiac devices, bone fractures, breast contours. So we have to look for this, okay. So these are the normal things. Now, so I told you before only, first of all, we'll have to describe the obvious abnormality and then we'll have to go for the systemic review. So what we will have to describe? The first of all, we will have to write about the what and where. That's it. Two things, what and where. So in what, we will have to write about the shape. So describe the shape of abnormality. Example, round, diffuse, well defined, ill defined, poorly demarcated. We'll have to write this part, okay. Then size, describe about the size of the lesion. Then density, say if it is hypo like dark or if it is hyper, if it is bright. So we'll have to say like hypodense or hyperdense, okay, compared with the surrounding soft tissue. Like this is the hyperdense lesion compared to the surrounding soft tissue, or you can say this is the hypodense lesion as compared to the surrounding soft tissue. Also, if it is homogeneous like same density throughout, or heterogeneous various density throughout. Cavitating lesion have a soft tissue rim with hypodense core and may contain air fluid levels. Like this we can see in this example. So this is the cavitating lesion and here we can see that hypodense core and here we have the air fluid level, okay. Is there any calcium or fat density associated? Suppose if there is a calcium deposition, we can easily identify the calcific density, okay. And after that we'll have to look for the associated factors like presence of lung edema. We'll have to look for the fluid level or air bronchogram within the lesion. For pleural effusion, we will have to describe which side is affected, comment on the presence of meniscus and how high the level of fluid extending. So we'll have to look for the meniscus like that. Look over here, this is the pleural effusion. We can see that on the left side and we can see here the meniscus, okay. So this is the presence of meniscus and how high the fluid level extends. We'll have to write that part. So we covered the what. In what we have discussed about the shape, density, and then we discuss about the associated factors. Then where? कहाँ पर है lesion? Yes, so we'll have to describe that part also. So where? So we'll have to look for the site first, say which side of the lung is affected and describe whether it is upper, middle or lower zone of the lung. This is much easier than trying to access which lobe is involved. You can directly speak that like this lesion is seen in the upper zone of the right lung like that. So it is very easy, right? So this is all about the chest X-ray reporting. What we have seen till now? Yes, we did introduction. In that we have seen the patient name, exposure, PAVO, APVO, whatever it is, date, okay. We will have to ask for the previous reporting. Then technical factors like rotation, inspiration, penetration, we discussed about that. Then we did about systemic review. Then we described about the obvious abnormality, how we will describe what and where, right? And at the end, on the pathologies and on the lesions, we will summarize in one part and we will give our differential diagnosis. So this is all about the reporting of the chest X-ray. I think you got the point. Now the next thing is, I don't wanted you to waste your 20 minutes. So I think it's better I will explain one normal chest X-ray and I will explain one abnormal chest X-ray. Fine? So look how I am explaining. So this is the case. 45-year-old female attends the emergency department with difficulty in breathing and sharp pleuritic chest pain. She had past history of anxiety, depression and hypertension. She is a non-smoker. Okay. So this is the history I have.
So how I will explain. So this is the PA erect chest radiograph of 45-year-old female done on dated so and so. I will ask any previous x-rays available for comparison, and then I will tell film is not rotated, there is a adequate inspiratory effort and penetration. So in this chest x-ray, this looking me as a normal, so I'm not going to explain or describe any pathology here. So the next part is systemic review, right? So first of all, airway. So I will tell the trachea is central, no evidence of free air in the soft tissue of the neck. Okay, first part. Then breathing. First I will speak for the right. So right side, the apex is clear, the lateral thoracic borders has no abnormality, the costophrenic and the cardiophrenic angles are visible, and the hilum is of normal size. It is positioned slightly lower than the left, that is normal, right? Then I will speak about the left side. The apex is clear, the lateral thoracic border has no abnormality, the costophrenic and the cardiophrenic angles are visible, and the hilum is of normal size and is positioned slightly higher than the right. Or directly you can say bilateral, like bilateral apex is clear, bilateral cardiophrenic angles, costophrenic angles are clear, like that you can speak. Then circulation. The heart size is normal, the aortic arch is visible, the left and the right heart borders are normal, there is no mediastinal shift. Then about the diaphragm. The hemidiaphragms are dome shaped with right slightly higher than the left. There is no visible free gas under the diaphragm. The normal gastric bubble is seen on the left side. Can you see here? Yes, this one. There are no lines or tubes projected on the films. The breast contours are present and symmetrical, and there is no evidence of previous surgery. There are no visible fractures or bone lesions seen. So this is how I will explain, and how I will give summary for this. So summary is, this is chest radiograph of 45-year-old female who presents with dyspnea and sharp chest pain. The chest x-ray is normal with no pathology identified. Additional investigations would be advised to establish the nature of her presenting symptoms. Like that I will explain. Okay. So this is about the normal one. Now I will explain one abnormal x-ray. So then another case is 64-year-old male was referred to respiratory department with 1 year history of progressive dyspnea and unintentional weight loss of 12 kg. He has no past medical history but is a smoker with 35 packs per year. So this was the history I have given. So now I will explain this chest x-ray. This is the PA erect chest radiograph of 64-year-old male done on dated so and so. Then I will ask if there are any previous chest x-rays are available for comparison. The patient is mildly rotated. There is adequate inspiratory effort and penetration. Now I will describe about the lesion. Okay, so here we can see the lesion, right? So there is a rounded lesion seen in the left lung located in the upper zone, projected partially over the clavicle. Now I am describing about the what part. So the lesion is rounded, demarcated. It is soft tissue density, homogeneous and non-cavitating. There is no consolidation around the lesion and no other lesions are visible. There is no calcification seen within the lesion. So this is the pathological things I will have to explain. Again we'll have to go to systemic review like airway, breathing, circulation, diaphragm, and then everything else part. The same like I have explained in the previous normal x-ray. So we'll have to repeat the same. Now what is my summary? So this is a chest radiograph of 64-year-old male who presented with dyspnea and unintentional weight loss for over a year. There is a soft tissue, rounded and well demarcated mass in the left upper zone with no associated consolidation. The appearance suspicious for lung malignancy. Further investigation with CT of the chest and abdomen is recommended along with urgent thoracic multidisciplinary team review.
So this is all about how to read chest radiograph, and this video is specifically curated for the Indian students. And till now you're watching this video, that means you liked the video. So please subscribe because it will make difference for me. Thanks for watching this video and have a safe future.